Hello and welcome everyone to the Menopause Symposium. Thank you for joining today. It's a pleasure to continue with these sessions where we bring you new and interesting insights from the world of menopause. My name is Basil Wata. I'm a gynecologist and a menopause specialist from London, and I'm joined by my friend and colleague Vikram Talawalkar, who is a fantastic menopause specialist and a gynecologist at University College London. Today, Vikram, we received quite a few comments on our website asking to speak about testosterone supplements in menopause. And I thought, what a better way to start on this than by the fairly well-known meta-analysis on the use of testosterone that was published in The Lancet a couple of years ago by Islam et al. It's coming from the labs of Prof. Davis at Monash Health. So I think this is going to be a very interesting session, and we'll talk about something very topical. So perhaps, as always, if you can maybe present to us the remit of the idea, the logic behind using testosterone in menopause, and what is the evidence gap?
Yep. So thank you for choosing this particular paper, Basil, because it sets the scene, so to say. So testosterone has been around now for quite a while, 10, 15 years. And it really has caught a lot of attention in the last 5 to 10 years. Of course, because of various guidelines that have mentioned testosterone, a lot of television and social media attention as well. Testosterone currently in the UK is mainly used for the indication of low or persistent lack of libido. And that is in relation to menopausal transition or post-menopause. However, there have been a lot of conflicting, so to say, reports or sort of arguments suggesting that the role of testosterone extends beyond sexual health, improving mood, improving energy, improving brain fog or cognition, as well as improving, of course, we know that it is beneficial for bones and muscle health. However, of course, most of the studies so far have concentrated on effects of testosterone in relation to sexual function, various aspects of sexual health. Very little has been done about mood, brain, cognition, energy, etc. So this paper, I think, is going to tell us a little bit about what exists there. What do we base our conclusions about testosterone in relation to sexual health or indication of low libido? How strong is the evidence? What are the side effects to expect, or are there any risks in relation to the use of testosterone, various products? And also, is there evidence in premenopausal women, not just the ones who are going through menopausal transition or postmenopause, and also about the other non-sexual health indications of testosterone and what we can think of doing better in future in terms of research. So let's take it from there.
Indeed, it's quite a lot to cover, and we'll try, and it is quite a lot of hard work to produce this meta-analysis, so we'll try to be sort of quite thorough in our sort of interpretation and critical appraisal. So this is a systematic review in a pairwise meta-analysis, meaning they compare testosterone to a comparator. Now, the interesting element is that, as you can see on the right side, they were not specific about what is the comparator. So it could have been placebo, or it could have been no HRT with or without testosterone. So that is, I think, a interesting methodological choice, because obviously that on its face value opens to a lot of heterogeneity in sort of what data you are pulling together. So the search was done from 1990 to 1918 with what you would expect in terms of standard search engines and databases to look into, and they primarily included RCTs that had at least done 12 weeks of giving testosterone treatment, and they were at least single-blinded. And the participant needed to be between 18 and 75. That tells me that they were okay to include POI, not just natural menopause and surgical menopause, which again might lead to slightly increased heterogeneity in terms of the sample size that we have. And they also included perimenopausal women. So that is something to bear in mind when, obviously, in meta-analysis is all about the PICO question and sort of the remit of what we're hoping to find data and pull it about. So data extraction, they followed a fairly standard methodology as per Cochrane, where two reviewers looked and extracted data from all the included RCTs in duplicate. They used the Cochrane risk of bias assessment tool, which is quite a standard sort of assessment to undertake, and they only included transdermal patches that gave 300 microgram of testosterone per day. So they were slightly specific on that. Statistical analysis wise, again, they used an interesting methodology in that they assumed when several studies are using the same measurement tool, that there was equivalency across them, and they used a mean difference for continuous outcomes. And for those that use different different measurement tools, then they use a standardized mean difference. Now, perhaps it would have been a wiser choice to use SMD for everything. It's hard to tell without going through each paper and evaluating all the different measurement tools that they have been used. But there is the point that I'm trying to make is that there's a lot of assumptions to maintain when you decide to use mean difference. And the other point that was interesting to me is that with SMD, they used inverse variance method, which is somewhat not recommended nowadays versus other methods such as RML that would give us more precision in the pooled effect estimate. But we'll take that within the limitation of the analysis that we have. And they assessed the heterogeneity in the trials using the I-square statistics, which is again quite standard, and reported risk ratios for dichotomous outcomes. They did plan two subgroup analyses. So this is for menopausal status and for the mode of testosterone administration. And interestingly, for the primary outcome, it was a very long list. I don't know, you can see that. I probably wouldn't call this as a primary outcome per se. It is rather extensive. And they for secondary outcomes, they looked into primarily adverse events.
Side effects.
I don't know. Do you agree that this list of primary outcome is perhaps what you would be most focused on in the meta-analysis on testosterone, or there were elements that you would prioritize?
Yes, this is extensive because it's looking at almost every effect of testosterone, the brain, the heart, as well as the sexual function. Probably one would have put primary outcome as the sexual function, all of those individual aspects, sub-aspects of sexual function, and others would have been secondary outcomes if say, I was to design the meta-analysis. But again, you probably are the expert, Basil, and I'll go by what your feel is.
I think it's quite comprehensive, and I can see the authors striving to offer the most comprehensive outcome. But again, I agree with you. I think we would have labeled sexual function as the primary one. But it's an interesting argument because even now we're sitting as clinicians and our academic clinicians in menopause. Is like, what do you take? How do you assess sexual function? It's quite a complex endeavor because do you use diaries? Do you use a standardized scale? Do you ask patients to remember? There is inherent recall bias when you are measuring sexual function because you're not capturing these outcomes momentarily. Rather, you're asking your patients to remember them after the event has taken place and probably on a weekly basis or more frequent. So they're not easy outcome to measure, and they're not very reliable in terms of like pooling. There will be a lot of heterogeneity, I'm imagining, across them. Other more objective outcomes, say cardiometabolic variables like BMI, is obviously more robust and more objective. Capturing sexual function outcomes is really difficult. And so quite an interesting choice of outcome indeed. Shall we move to the results and see what they found?
Let's see. Yeah.
So they included 46 publications reporting on 36 randomized trials. And out of these, 13 studies specifically recruited women with low sexual function reported, and one actually measured the levels of testosterone in the blood before randomizing them. About a third of these actually used an oral preparation of testosterone. 13 used the patch, 2 used the cream, Two used gel, one used the spray, one was a sublingual formation that I actually did not know it existed until I read this. And there was an intramuscular injection in one trial and a subcutaneous implant in one trial. Quite an interesting variation in methods of delivery of testosterone, isn't it, Vikram? I think in the UK we only use mainly gels. Are you aware of other forms we can use in the UK or other nearby countries?
So gels, of course, are the majority, but you do have implants. Not many NHS units offer implants now, but it's mainly the private sector.
Yeah.
And the other one is sublingual. I have had a few patients from other clinics who have had lozenges for testosterone. So those two are not very common, but used besides and the patch now is being trialed. So you're going to have the trial of the patch starting this year. So let's see if it's available in the next year or so.
100%, quite interesting. And so looking into the results, now compared to placebo or a comparator, what they found is that testosterone was associated with a significant increase in satisfying sexual events and frequency of satisfying sexual events. Now, interestingly, they reported a 95% prediction intervals. And to explain that to our viewers is basically telling us not just because there is high heterogeneity, as we can see in the I-squared statistics, it's not that high. It's, I would say, medium, 30 and 40%. What the prediction intervals are telling us is that how the effect is changing across the wider spectrum of all the different population in data was pooled across different trials. So basically, it's saying that some of these women did not see any improvement, and it was minus 0.1, and some saw quite a lot of improvement of 1.8. But however, on average, the mean difference was 0.8, which is a significant difference. And testosterone was also associated with augmented sexual desire, arousal, orgasm, pleasure, responsiveness, and self-image. Now, the interesting finding is how much the mean or the standardized mean difference is changing across these different variables, and arguably this has to do with the methods or the measurement tools they used. But if we look at arousal, it was at orgasm it was 0.25, but then pleasure is 6.85, so significant difference. And these are SMDs and MDs to bear that in mind. But the key message here to take is that they're all going in the same direction, which is that there is benefit. Now, there was no clear benefit in increasing the frequency of satisfying sexual events, the total sexual function score, or any sexual function score domains that were within the available trials, but there are actually very few trials that reported or used these. Now, if we look at the forest plot, the interesting interpretation is that there are no major outliers, and most of these trials are actually yielding very similar effect estimates. It's very close to the line of null or zero, and showing that there is some benefit from testosterone, but it's not going to be humongous benefit. There is some small benefit, and we have to bear in mind that this will not play out the same for everyone. So not everyone will bear the same benefit with testosterone given by the 95% prediction intervals that the authors are reporting. However, on further examination, you can also spot some clear outliers. So for example, the study by De Paula et al., it's going in completely opposite direction. It's the MD is 3.5, while everything else is in the 0.4. So one would question what happened in that trial, or whether there is any something specific that caused such outlier. And similarly, in this study by Huang et al. In the surgical and natural menopause, the effect was reversed. So again, these outliers warrant further sort of analysis and exploration, which I could not see in the meta-analysis. They did not report on it. Do you think the magnitude of benefit is reflecting what we see in clinical practice, Vikram?
Yes, very much. I think there is benefit, there is improvement, but it is modest for many. And of course, The outliers, you could say the sample size, I think, was very small for both of them, isn't it?
Correct.
So maybe that could be skewing the result too much in one direction or the other. But you're right in the sense that most studies pretty much say the same thing. There is an improvement, but it will vary from individual to individual, and the effect may not be huge, a little bit of an improvement to say in sort of lay terms.
100%. And I think it's important so that we can moderate the message in terms of setting the expectations for patients in the clinic on, because they all come seeking testosterone after hearing about it in social media. But it's important to send the message is not a wonder drug. It's not going to really change things significantly, although there might be benefits. Now, moving on to an important element, which is what are the side effects of testosterone. So those that gave testosterone orally, they noticed that there is an increase in LDL cholesterol, which was significant, as well as a reduction in total cholesterol, HDL cholesterol, and triglycerides. So this is something I don't really see in my clinical practice because most of the time I would be prescribing gels. And so it's an interesting variant on why we would be giving testosterone orally. And there were only, I think, 3 RCTs that reported on any cognitive measures, and there was no significant improvement within these 3 RCTs. Similarly, there was no significant change for bone mineral density, body composition, or muscle strength, or any of the psychological and well-being outcomes measured. So that highlights an interesting gap, isn't it, in terms of what further evidence we need about it. Other side effects that were found to be significant is increased acne and hair growth, which I counsel all of my patients about, and I think every menopause specialist will probably do the same. And there were no significant adverse events with testosterone. So that is mainly cardiovascular events like myocardial infarction, stroke, and deep vein thrombosis. Now, an absent element here was cancer, and whether there is any correlations with testosterone with any other cancer. Arguably, these are all short-lived RCTs, and they'll probably be too short to capture that. But what are your thoughts in terms of testosterone association with cancer, so that we offer a more comprehensive element in here coverage?
But so far, it seems if you stick to the dose that's recommended, which is sort of upper normal level of physiological range, you're not giving excessive doses that cause clinical side effects or very high levels of testosterone, then I think there's reasonable evidence or sort of experience for last 10, 15 years to say there's no obvious link with any cancers. There has been criticism or argument that some of the testosterone can get converted into estrogen in the body, so it could be associated in the long term with risk of some cancers. But clinically, that effect hasn't borne out yet because the levels are, I think, so small, or the doses are so small. So far, so good. Data are reassuring. Whatever 10, 15 years of observational or randomized data we have from small or moderate studies.
I agree with you, and I think it'll be difficult to see that within the context of randomized trials. There'll probably be more follow-ups of randomized cohorts that are very well sort of phenotypes and followed up. Now, an interesting variant as well in terms of risk of bias across all included studies is that about half of them had attrition bias or high attrition bias due to data loss. You could argue that this is due to the placebo effect. However, as we saw, most of the outcomes reported primarily are subjective. And so one would expect to see a placebo effect in this. And an interesting element is that to see, because the impact of testosterone or the margin of impact is not very wide, I think a more important exercise would have been to split those trials that compare to placebo and those trials to compare to routine care, because it will be very important to actually quantify what is the placebo effect in this context, specifically when using subjective outcomes towards quantifying sexual function. What do you think on that level?
Yes, I mean, placebo effect is definitely there. What you want to know is how much is it, and then on top of it, how much is the contribution from testosterone. I think there are some data related to that. I'm not sure which papers or which ones they are right now. But I think in the context of this meta-analysis, yes, it would have been useful to know how much the effect of each is, and how much then it matters in terms of the result we saw on the forest plot. How much of contribution was there from the placebo effect in either reducing or the extra effect of testosterone in
Yeah,
that particular graph.
100%. So I think it's a lot of hard work to put this meta-analysis together due to obviously we summarized a lot of data very quickly, but it's quite extensive. Few things that we already mentioned in terms of limitations. So the high attrition bias, the variation in outcome reporting, and as we previously discussed in previous sessions, we are advocating for the need to use core outcome sets, and there is one that is available for menopause in all future RCTs, which will make evidence synthesis more meaningful and comprehensive. As we briefly touched upon, is really hard to evaluate sexual dysfunction due to the limitation of available measurement tools. I think we should probably move towards an electronized diaries where you can collect these over mobile apps, something to hopefully see in the next few years. And there was also variation in terms of how long the intervention was given. So some of these trials were given it for 52 weeks, while others were for 12 weeks. And you would clearly argue that with longer use of testosterone, you would see more pronounced improvement. I don't know, in your clinical practice, how long do you tell patients it will take to see some benefit from testosterone? How many months?
It's very variable, I must say. So some women will start using it and notice effects within 2, 3 weeks,
Mm.
pretty quick. Others might struggle to notice difference for 12 weeks or 16 weeks. And some may almost be in a state where they want to give it up around 5, 6 months, but persist and then start noticing some difference. Again, it's such a complex area because there are so many confounding factors. Your lifestyle, your social factors change in the background, and how much of it is the actual testosterone and how much is the background factors is very difficult to differentiate. But generally, one would say if someone is trying it, try for at least 3 to 6 months, because you might be late in noticing effects, and that might be the time where you decide you stay with it or you come off it.
I agree, and I think, and then so something that would have been nice to see. I think there's a great need for a meta regression to see, and also sensitivity analysis, to explore these outliers that we saw, but we can put it down to small study effect. But other important factors are commonly disregarded when it comes to menopause sort of meta-analysis, because you have latency effect, how long they've been on HRT, the actual type and dose of the HRT, because that does play an impact into the outcome that we are assessing, which is sexual function, the dose of the testosterone. And again, there's
And whether it was absorbed, because they might be using it, but actually, was it being absorbed and detected in the blood, for example? Because not everyone did blood testing to see what the levels were.
exactly, especially if you're using gel, which we know is messy, and you tell them
Variable.
precise amount, but not everyone would have adhere to it every day of the week. So all these elements add to a little bit of
Complexity.
and lack of limited generalizability of the results. Other factors that I think we published an article arguing for this in terms of other important elements to bear in mind when mentioning that is that not just that if it was surgical menopause or natural menopause, but also how long has it been since the menopause, and how long has it been they are on active treatment or off active treatment before they take testosterone, as well as other sort of medical comorbidities. I think these are all very important elements that they were not examined here, arguably because of data limitation, and it's not easy to make a lot of assumptions in meta-analysis. But I think age is an important factor that was not looked into, because those who are in their 40s, 50s and perimenopausal will behave completely differently to those who are 60 plus that are going on testosterone. So overall, I think we definitely need an IPD meta-analysis on this in this domain, where we can adjust for all these covariates and confounders and try to really elucidate the true effects estimate of testosterone in these subgroups. But as you mentioned, hopefully there will be a new trial, isn't it? Funded by
That's
the
the plan. I
NIHR.
think the NIHR was trying to set up a trial to look at non-sexual benefits of testosterone. Hasn't happened yet. Hopefully, few scientists will come together to get the trial going in the coming year or two.
Indeed, and hopefully we will be bringing the results to the symposium very soon. So overall, quite a lot of work went into this meta-analysis. I think it's definitely to be applauded, and it adds a lot of evidence to inform clinical practice, but there's still quite a lot of unknowns, and we definitely need some more research. So bottom line, do you agree with the statement that testosterone is here to stay, and we will probably be using it more and more in menopause clinics?
Very true, Basil. So it's good that the testosterone has received the attention, which it was lacking for many years. It's good we are using it now when we know that the cause of low sexual desire is not something like antidepressant. It's not the vulvovaginal atrophy. It's not the painful intercourse. It's not because of psychosexual issues like partner issues. So as long as you know that this is definitely hormonal, you've ruled out the common causes and you've offered it as a trial, a lot of women will benefit, even though it's modest. Some will have more benefit, and a lot of women will derive benefit. Others who may not benefit, of course, will not be subjected to any major risks or side effects. So the good thing about testosterone is it's got benefit, but no major side effects or risks like with HRT.
Yeah.
So other than making sure that you're not going over the dose, making aware that there may be some acne, hair growth, other than that, it's pretty much safe to give it if you think it will benefit.
I agree, and that's one of the arguments that I don't really understand why currently in the NHS is made as a provision in secondary care only. If it has very low side effects margin and it's largely safe, why we're asking all women to come to see a menopause specialist rather than at the GP?
Well, that will change. I mean, that is changing. A lot of GPs now are taking active interest into, say, becoming menopause specialists themselves or women's health GPs. And actually, I'm seeing, at least in the UCLH area, that a lot of GPs begin testosterone if they have had some sort of training or if they are confident with the menopause management. And that's great to see. Others may have limitations because it's still off license. We don't have a license preparation. Similarly, of course, not all GPs may have updated and had the training about testosterone through BMS or FSRH. And so often they may not find that they are confident to initiate it, but happy to continue. I think as time passes and more people get trained, you'll see more and more primary care using testosterone in the next few years.
I agree. And I think we still need also a lot of research in terms of the clinical pathway for provision of testosterone, because
Yeah.
so far it's been on the basis ask for it if you need it, while in reality, most women, when they come to the menopause clinic, you ask them, how's your libido? And they sort of brush it off. They don't think about it unless aided by a specialist to explore it, I think, in that sort of stage in life. So perhaps it become a routine part of every HRT, given we don't know yet. I think definitely more research to be explored on that
Very
front.
true. Very true.
Fantastic. Well, thank you very much, Vikram. It was quite a stimulating debate today. Thank you for all our viewers for tuning in and waiting for future sessions. If you have any comments, please write them down below or send us any questions on our email on the website, menopause.co.uk. Don't forget to subscribe to our channel and join our newsletters, and hope to see you in future episodes of the Symposium. Thank you very much.
Thank you. Thank you, Basil. Thank you, everyone.